Hello, I am Naveen Kumar, a second-year GI fellow at the Brigham and Women's Hospital. It is my honor to be here with my mentor, Dr. John Saltzman, Director of Endoscopy at Brigham and Women's Hospital and an Associate Professor of Medicine at Harvard Medical School, here to discuss our upcoming article in GIE entitled Initial Management and Timing of Endoscopy in Non-Variceal Upper Gastrointestinal Bleeding. Dr. Saltzman, as you well know, upper GI bleeding is a very common reason for hospital admission, with an estimated mortality rate of 2 to 14% and high associated healthcare expenditures. In your practice, what are the first steps you think about when you see a patient presenting with an acute non-variceal upper gastrointestinal?
So as patients present with non-variceal upper GI bleeding, the initial thought, oh, this is an upper GI bleed, should be accompanied by, we need to start resuscitating this patient. So you need to get the 2 large bore IVs in, which is a 16 to 18 gauge IVs each, and start assessing the hemodynamic status of the patient. Are they hemodynamically unstable? Should you do orthostatics if they appear stable? Get the lines running in, typically isotonic fluids are giving, and then try to assess, is this an active, ongoing bleed? Get the basic blood tests going. I start oxygen if I'm concerned about basic blood, big bleeding as well. So I just get the ball rolling, get the blood tests going, get them stabilized as I'm starting to assess them. So it's unlike other areas where we're just thinking about the diagnosis. Here we're acting as we're going along.
Excellent. It is common for us to see patients on warfarin therapy presenting with an upper gastrointestinal bleed. Do you have in mind an INR threshold before you will take such a patient to upper endoscopy?
Yeah, that's an excellent question. And this has been looked at several times. And the question is whether there's an INR threshold above which endoscopy or endoscopic therapy would be unsafe or ineffective. And in the several studies that have looked at this, including one that was here at the Brigham, we found that there was no threshold up to an INR of about 2.5, 2.7. This has been replicated by other groups, including a Canadian collaborative study. So the guidelines now reflect this, that it's safe to do an endoscopy and can be done effectively up to an INR about 2.5. If it's above 2.5, I will bring it down. And then what happens after you do the endoscopy depends on what you find. If you did an endoscopy at an INR of 2.5 and it's a clean base ulcer, you don't have to do anything further. Whereas if you found active bleeding, you need to treat it. Those patients, generally, you keep bringing down the INR to follow. So I don't worry about INRs up to about 2.5. Endoscopic therapies are effective, both clipping and combination therapies.
Very nice. On the same topic of anticoagulation, direct oral anticoagulants, or DOACs, have become quite common, primarily due to their fixed oral dosing and lack of need for routine lab monitoring. When you see a patient who presents with an upper GI bleeding on a DOAC therapy, how do you think about managing those patients? And are there any reversible agents that are now available for us to treat patients with?
Yeah, this is a challenging situation. The person who's on one of these newer drugs, the direct-acting oral anticoagulants, they either work on the 10A or the thrombin sites of the anticoagulation cascade. And we're seeing lots of them now as the population ages and people have more indications to be on these medications. And the first thing I look at is, when did they take their last dose? If their last dose was 24 hours ago or longer, I look at their creatinine clearances, because most of these drugs are renally cleared, and I get fluids going to try to wash it out. Unfortunately, most of them have taken their dose within the last 24 hours. We can't easily measure how anticoagulated they are. If they've taken in the last 2 hours, you can give charcoal and bind the medication. But if you're faced with a patient who seems to have active or serious bleeding, so until recently, there were no good options to treat these patients and reverse them. What we were given were the protein complex concentrates, and these have activated factor that can help. But recently, there have been some that have become available. There is a monoclonal antibody that helps with dabigatran, which acts at thrombin, and it can be given as 2 doses, and it very effectively will reverse the anticoagulation within minutes. In addition, there's another drug called Endexanet alpha that has is currently undergoing testing, phase 3 and phase 4 trials. Recently, there was a trial in the New England Journal that showed it's very effective at the 10A inhibitors. So this is the apixaban, doxapan, rivaroxaban. You can reverse it. So it's a little different acting. It's a decoy protein. You give a dose, and then you have to follow with a continuous infusion. This is not clinically available, FDA approved as I'm talking to you, but we know that the FDA is looking at this, and we're hoping that this is approved in the near future. And there are hospitals right now that are participating in studies about managing patients with GI bleeding that have this available now.
Very nice. So prognostic scores such as the Glasgow-Blatchford score or AIM-65 score are helpful to risk stratify patients presenting with acute non-variceal upper gastrointestinal bleeding. Do you typically calculate these scores when you're evaluating a patient for the first time? And how do you decide between using one score versus the other?
Yeah, so this is an area where, at least since 2010, the International Consensus Guidelines recommended that we incorporate risk scores in our assessment of GI bleeders, very much like we use ransom criteria for patients with pancreatitis. The 2012 ACG guidelines also recommended incorporating risk scores, and they're not widely done. There are two good scores that are calculated in the emergency department at presentation. You mentioned them. The Glasgow-Blatchford score has been more extensively studied, and its value seems to be in patients who have very low scores, such as a 0. That patient's at very low risk of further problems from their GI bleeding. And so most of them could be managed as an outpatient discharge from the emergency department, provided they're reliable and you can have follow-up arranged for them. On the other hand, higher risk patients have a Blatchford of 10 or 12, may need to be watched more intensively, maybe need to have watched in the intensive care unit. The other score that's out there is the AIM-65, which we came up with. We derived and validated it in Pennsylvania, and we've shown that it works in other populations. And that score is not all that sensitive at low populations. So an AIM-65 of 0 is helpful, but it's not completely reassuring that that person could be an outpatient. Scores that are above, a 2 and above are considered high risk, and I consider 3 and above at very high risk. So I actually calculate both of them. The AIM-65 you can do off the top of your head because it's just each is a 1-point variable to calculate. The Blatchford score is 8 different categories, and they're weighted so you can get between 0 and 23 points. And so there are calculators that are easily available to help with that. So I calculate both, and both on one end for the low-risk patients, maybe we can manage them as outpatients, and then on the higher end, who's at risk of poor outcomes, rebleeding and mortality, and then who should I direct my resources to.
This discussion of risk is very pertinent to the question of timing of endoscopy. As we all know, current guidelines recommend that endoscopy be performed within 24 hours for patients presenting with non-variceal upper gastrointestinal bleeding. How do you think about patients who would benefit from more urgent endoscopy, and is there any advice you have for the practicing gastroenterologist when faced with this issue?
Yeah, this is another very common scenario to all of us, of patients in the emergency department or come in the ICU and we're consulted, and the physicians caring for them are very worried, want us to come in now and do the procedure. Should we do it on presentation? Is there a value of coming in early? And interestingly, it's not been proven where there's value. It intuitively makes sense that somebody who has ongoing bleeding would benefit from an early endoscopy. And to me, those are the ones who I'm most worried about. So somebody who comes in with hematemesis, who comes in hemodynamically unstable, those are the ones I'm going to think about as soon as they're stabilized to go ahead and proceed with endoscopy. But on the other hand, if you come in and do endoscopy too early on a patient, they may not be stabilized yet. As we mentioned at the beginning, the most important thing to do is resuscitation. And if patients are under-resuscitated and you start in your endoscopy and sedating them, they may collapse hemodynamically and do poorly as well. So they have to be initially resuscitated well, and then you can go in and do your endoscopy. The other issue is what's the time of day? If it's in the middle of the night, You may be tired, your function may not be as good as it normally is as an endoscopist. You may not have your usual supports, your endoscopy nurses or technicians. You may not have the backup that you need. Your surgeons may not be in the hospital, your interventional radiologists. And you have to think before tackling a bleeder, do I have the right infrastructure and support, or am I better off waiting till the next morning? And often the answer is that you're probably better off waiting. What the studies have shown is if we come in early, we find more findings. We find more active findings that need treatment, so we do more treatment. But in general, patient outcomes are not different. Patients don't have more blood transfusions, their rebleeding rates are about the same, their surgery rates and the mortality rates are about the same. So at this point, we're not able to distinguish clearly who would benefit from a very early endoscopy and who just within that 24-hour period is an appropriate time. But I think 24 hours is an appropriate time, because if you go longer than that, then you're not finding things, and there are patients who could really benefit from from an endoscopy and therapy who will not be receiving it.
Thank you for that excellent summary. I think this question of timing of endoscopy is so relevant for all of us that practice gastroenterology. Where do you see, are there future areas of research that you would like us to pursue, that you'd like to see the field of gastroenterology pursue in terms of this exact question of timing of endoscopy?
Yeah, I think the main thing that's happening in timing of endoscopy is the convergence of several of the concepts that we just spoke about, is the risk scores. Can you use these risk scores to prognosticate and pick who is at risk of poor outcomes such that you should come in early? And there is one study that was a retrospective study in over 900 patients that looked at patients who had a Blatchford score of 12 or greater compared to who had less than 12. And 12 is a high number, so that's a high-risk patient by the Blatchford scale. And they looked at timing of endoscopy. If your Blatchford was lower than 12, it didn't matter whether you came in early or with any other time within 24 hours. The patients did about the same, and they did well. However, in this one retrospective study, if you came in within the first 12 hours in the high-risk patients, you reduced the mortality rate from 44% to 0%, suggesting that we can identify patients using these risk scores who may benefit. And this is where the current studies are heading. Can we use these scores, either the AIM-65 at a high level, the Blatchford at a high level, and can we use that to predict who would benefit from an early endoscopy after resuscitation, though it has to be after resuscitation.
Thank you so much, Dr. Saltzman, and all our viewers at home. We hope this interview was helpful, and please do refer to our upcoming article entitled The Initial Management and Timing of Endoscopy in Non-Variceal Upper Gastrointestinal Bleeding in GIE. Thank you so much.
Thank you, Naveen. It's my pleasure to talk to you about our upcoming article.